Good evening, everyone, and hello. My name is Don Lytle. I'm the CFMHN webinar coordinator, and I'd like to welcome you to tonight's webinar. Our presentation today is titled Newtonian Science, Complexity Science, and Suicide Research. Thank you all for attending today. But before we do start this session, I'd like to go over a few housekeeping items to help ensure a smooth presentation tonight. We ask that you mute yourself until the Q&A session at the end of the presentation. Should you have a question during the session, you can either place it into the chat box or you can hold it until the Q&A session begins at the end. As the moderator of the webinar, I will monitor the chat box and facilitate the question period at the end. And finally, please be aware that today's presentation is being recorded. Thank you. We're thrilled tonight to have joining us Jennifer Olarte Godoy as our speaker. Jennifer is a PhD nursing student from McMaster University and a nurse educator for the Mental Health and Addictions Program at St. Joseph's Healthcare in Hamilton, Ontario. Jennifer completed a master's degree of nursing at the University of Toronto with a specialization in addiction studies and has clinical experience in inpatient acute psychiatry, concurrent disorders, and psychiatric emergency services. Jennifer's research interests include therapeutic relationships, nursing interventions, and mixed methods research approaches. So please join me in welcoming Jennifer to the webinar series. So take it away, Jennifer.
Thank you. Okay, hope everybody can see my screen now. Now, before I begin, I do want to acknowledge that I am speaking to you from Hamilton, Ontario, and to recognize and acknowledge that Hamilton is located on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. Now, before I begin with the topic on its own, I do want to give you some context as to why I'm even talking about Newtonian science and complexity science when it comes to suicide research. And to ask you all to take a moment and to think of knowledge, scientific knowledge, as something that is created by humans. And humans hold assumptions and values about how the world works. So as Dawn mentioned, I am currently a part-time student, a PhD student at McMaster University, and I had the privilege a couple of years ago of taking a philosophy of science course. Now, before that, with my team in my work as a nurse educator, we were doing a lot of work in looking at our suicide prevention policies and procedures. And within that, we talked to a lot of people. We talked to many clinicians, we talked to many patients, we talked to a lot of psychiatrists, a lot of experts, and we learned a lot. And at the same time, it left me personally with some very complicated questions. So for example, is suicide something that is preventable? Is suicide, if it is preventable, how preventable is it? Is suicide something that is predictable? And if so, how predictable is it? So as I was taking that philosophy course, I decided to then look into the literature as it relates to the philosophy of science and to try to answer some of these questions, which I think leads to a lot more questions, which we're going to go over. So this is what brings me to this topic and this presentation today. So throughout the next several minutes, I'm hoping that I'll be able to provide you with an overview of Newtonian science as a basis for suicide research and knowledge development. Now, this is a very brief, superficial overview, as well as an overview of complexity science as a basis for suicide research and knowledge development. And throughout the presentation and at the end of the presentation, we will discuss some clinical practice implications to the care of individuals experiencing suicidality as we take these ideas and concepts into account. So, as everyone in this room is aware, suicide is a significant problem. More than 703,000 people, and counting at least, die by suicide every year, and many more people are affected by these losses. We also know that given the prevalence of suicide and its impact on people, on communities, there has been a lot of research done on trying to understand it and prevent it. Yet we also know that the overall number of suicide deaths has not decreased. Instead, it has increased worldwide, in some places more than others. In Canada, for example, our rates of suicide have remained relatively stable over the past 30 years, yet there are significant disparities in the suicide rates between different groups of people, particularly between First Nations people and non-First Nations people. In countries like the United States, rates of suicide have actually increased by about 35% over the past 30 years. So in terms of suicide research is complicated and it's challenging, and that's for a number of reasons. First of all, people who die by suicide can't tell us exactly what led to their death. They can't help us understand that. Many more people attempt suicide than those who die by suicide. And finally, suicide is on its own very complex. There are multiple interacting variables in a complex time course that is difficult to study using our traditional research methodologies. Yet, most of suicide research to date has employed a positivist paradigm, meaning a paradigm based on a Newtonian worldview that we'll discuss, that has the inherent assumption that there is a linear causal mechanism to suicide, and that if we identify risk factors and stratify risk, we can predict suicide and therefore prevent it. So it looks something like this. We identify risk factor and risk factor and risk factor, and based on that equation, we determine if somebody may be at low risk, moderate risk, or high risk of suicide, and then we allocate the appropriate resources or intervene accordingly. Another way to think of it is, for example, Joyner's interpersonal theory of suicide that you may be familiar with, and it states that it's a quite influential theory. And it states that if an individual feels as though they don't belong, so I'm missing my graphic, but that's okay. If an individual feels as though they don't belong, and they feel as though they are a burden, and they are not hopeful that those two things are going to change, and they acquire the means to die by suicide, then they are very likely to attempt a suicide. So again, it is one factor plus one factor plus one factor equals to a person being at very high risk of dying by suicide. So it's this linear causal mechanism that we look at, that we think of, that we study. So how is this based on Newtonian science? So this is a very brief superficial overview. Newtonian science holds the view that all phenomena is constituted of matter. Now, this includes mental phenomena, it includes psychological phenomena, social phenomena, and so forth. And it believes that any change or movement of this phenomena is therefore governed by the laws of nature. So what we try to do is we try to reduce phenomena to its individual components and to try to understand what are the distinctions between the components. So we try to put together this puzzle of a human being, for example, to try to understand what are the differences and how then do we move forward. So it also assumes that the whole is equal to the sum of its parts, and that an object of study is influenced by a finite number of internal and external factors. What that means is that if there is a finite number of internal and external factors, and if we can identify what all of these factors are, then we can make predictions about what will happen. It also means that if we are able to then tease out the psychological, social, biological, environmental factors that may lead somebody to take their life, then we can develop effective interventions, and with appropriate measurements, we would have fidelity of these interventions that would lead to expected outcomes. So again, there's this linear causal mechanism to things that happen that we can identify and predict and therefore prevent. Now, if we look at the literature and some of the things that we have learned, is that Newtonian science is primarily what has fueled most of suicide research to date. And it's easy to see how. Number one, most of suicide research to date is quantitative. The majority of suicide research is related to risk factors. So we have a lot of knowledge about different risk factors for different populations. What we don't know is how these risk factors are related to suicide for a particular person. Now, again, the idea of doing this work is that we can establish risk factors, do our equation, and figure out how to best intervene. Now, the reality is that there was a meta-analysis done in 2017 by Franklin and colleagues that found that in using risk factors to predict suicidal behavior, this is looking at 50 years worth of research, prediction was only slightly better than chance, and our predictive ability in 50 years had simply not improved. Now, what they found is that many people that were deemed to be at high risk of suicide did not die by suicide, and many people who were deemed to be at low risk of suicide did die by suicide. So basically, what we learned through this very large study, looking at many suicide risk assessment tools and what happened thereafter, is that our ability to predict suicide over the past 50 years has been slightly better than chance. Now, the second most abundant type of research is that of biological research. So this is where we're looking at neurotransmitters, we're looking at hormones, we're looking at pharmaceuticals, we're looking at brain imaging and so forth to try to understand what is associated to suicide at that basic molecular level. And lastly, Joyner's interpersonal theory of suicide that I described briefly earlier has been very influential in suicide research. For example, there was a meta-analysis that was done that looked to test its hypothesis, and they found 122 studies that fit their criteria that were looking again to see if Joyner's interpersonal theory of suicide if they could prove its hypothesis. And they found that to a certain degree, but not fully at the end of the day. Now, what about all this other things that may not fit within our puzzle piece? So one of the criticisms about theories like the interpersonal theory of suicide is that it implies that the ultimate origin of suicide lies within the person. So basically, the decision to end one's life is a product of a sum of personal factors for an individual. Now, some critics suggest that this view undermines the role of social issues, oppression, politics, stigma, and power inequalities as being part of the context in which suicides occur. And it's easy to see that the sociocultural context that extends beyond the individual has a significant impact on suicide. Just looking at the rates of suicide in Canada and how they compare between First Nations and non-First Nations people. For example, Inuit people have a suicide rate that is approximately 9 times higher than non-First Nations Canadians. So one of the implications of this research and this knowledge that has been developed looking at the individual is that we cannot generalize those findings to a population that is impacted by different social, cultural, and political factors. So now this brings us to complexity science, and this is that brief overview that I will give you. So complexity science is different than Newtonian science in that it holds the assumption of holism, meaning that the whole is greater than the sum of its parts. It does not align with this puzzle piece kind of view, and instead it looks at the concept of emergence. Now, emergence means that parts cannot be reduced to the properties of its components. So it looks something like this, and you see around each part, they mesh with each other, they're messy, they're complicated, and the borders are not linear, they're open because they change. So the second part of emergence is that new properties emerge as a result of interactions between the parts. So all these different components are messy, they're together, and they give rise to new parts in a non-linear way. Now, it's not all messy. there is something to it that we can identify. However, the other part of complexity science is that entities are considered complex adaptive systems. So instead of looking at an individual or a person, we look at a complex adaptive system. And these are systems that have these indeterminate boundaries, and they consist of components that interact with each other in nonlinear ways. They also belong to environments that are more complex than the system itself, which makes it difficult to control or predict its effects. So basically, everything is so complicated and interacts with each other and changes each other through its interactions that we simply cannot make predictions about what will happen. Now, the part where there is some order to it is that it believes that when the systems interact over time, trying to adapt to their environment, they form patterns. And these patterns are the aim of science when it comes to complexity science. So we're looking to understand the interactions between the whole and how it leads to certain patterns within a system. So you see these little red dots. These are the patterns that we're seeing when we study a system that intertwines with each other, and its properties try to adapt to the environment from which it belongs. Now, we're going to move back to Newtonian science for a little bit and then back to complexity science. So some of the implications of suicide research being primarily studied through the concept of Newtonian science is that if we hold the assumption that an object of study is influenced by a finite number of internal and external factors, then again, we have this idea that if we can identify and control for all these factors, we can make predictions about what will happen. So some of these authors have stated things for us to think about, such as if suicide is being viewed as a preventable cause of death, that implies that either the suicidal individual or those close to the individual can determine risk in time to prevent death, which ideally we can do. The other thing to consider, and this is Cilliers, who is a complexity science person, is that if our knowledge is limited and we cannot claim a purely objective status for it, then we can also not use that knowledge as if it is so. So it begs the question, is that what we're doing? Are we thinking of the knowledge that we have related to suicide as something that is objective? And are we acting as though it is so while potentially missing some other components? These authors call for clinicians and researchers to shift attention away from probabilities of risk and instead shift attention towards the needs of the suicidal patient at any given time. They propose that it is time for clinicians and researchers to acknowledge to our patients, their families, the healthcare systems, and the courts our inability to categorize individuals according to a probability of risk. Now, I'm not saying necessarily this is the way to go. It's just something that I think we really need to think about and consider, and how this influences not only the work that we do, but our patients, their families, and the healthcare system overall. So thinking about these implications, again, if it is assumed that suicide is preventable through conducting a risk assessment and intervening based on the estimated level of risk, then it may also be assumed that if a suicide or a suicide attempt occurred, there must have been a human error in the risk assessment calculation. And we want to say, and we want to believe that this does not happen. However, some studies show us otherwise. In this meta-synthesis by Chloe Garcia and colleagues, they found that nurses feared that their organization would take legal action and blame them if they were unable to prevent a suicide attempt. Other organizations may hold a suicide in the inpatient setting, for example, as a never event. And never event is something that is an adverse event that's extreme, and that we assume, the definition of never event is that we assume that we can prevent it if all checks and balances are done. Now, beyond this, the healthcare setting, this group of researchers found through a qualitative study that discussions regarding suicide for nurses were based on a preventative risk framework where professional responsibility and accountability was emphasized. Now, what does this do? This leads to nurses fearing about patients harming themselves and prioritize minimizing risks. Now, this on its own leads us to take a very risk aversion type of approach, where the focus of the nursing work becomes that of limiting people's belongings, for example, limiting freedom. And of course, this is important and it has to be done in certain circumstances. The issue becomes when this takes over and it becomes the nurse's only way to addressing suicidality. Now, the other thing to consider here is that measuring successful outcomes is nearly impossible when it comes to suicide. So if we think about it, we can never really truly say that a person chose not to die by suicide based on a particular intervention. I mean, they may tell us that, of course, yet there are many factors surrounding this intervention. There is the clinician, there is the environment, there is the context in which it happened. But it is really, really difficult to measure successful outcomes when it comes to suicide. I mean, I personally believe that suicide is prevented every day by nurses and by other healthcare providers and by family members, yet it's really difficult for us to count that. What we can count, however, is the times in which our work doesn't change that, and the person may die by suicide anyways, which can, of course, is really difficult for nurses, for clinicians, for everybody involved. Now, the other implication of this whole thing is that if nurses have this fear and anxiety about patients harming themselves, it can take away from other factors such as therapeutic relationships and instilling hope. If we are focusing on minimizing risks and doing standardized assessments, then we may not have as much time or energy to focus on that therapeutic relationship, which on its own may have a greater impact on influencing suicidality. In addition, the use of standardized risk assessments, if they're not complemented by a certain center focus, may narrow our perspectives as to the multiple likely interrelated factors associated with suicidal thoughts and behaviors for that particular person in their particular social, cultural, and political context. If we're using this tool that maybe was developed with a different population in mind than the person in front of us, we may miss some of the things that are really important for this person in particular and their thoughts of living versus dying. So in a nutshell, talking about these implications, again, some things to consider is that Metzland tells us that human beings, unlike the parts of a machine, are constantly influenced by an infinite number of factors and experiences. Experiences, according to Lennon, are generally unpredictable, non-random, and have been physically shown to alter the brain's functionality. And really, a Newtonian worldview that does not recognize the emerging, dynamic, and unpredictable nature of human beings does not truly reflect the complexity of the multiple factors that may lead somebody to take their life. So, of course, Newtonian science is wonderful. It is why we're able to have this webinar all across Canada and the computer, and it's amazing. But the argument that I'm having you think about is that, does it fit something like suicide? And is it influencing the work that we do in ways that take away from our patients and from the care that we provide? So speaking of complexity science and nursing, so complexity science and nursing clearly have some things in common. Humans and the environment continuously evolve. This assumption is held by both. Complexity science and nursing hold the assumption that the study of relationships and interconnectedness is fundamental. And finally, that the domains of person, health, environment, and nursing are interdependent constructs that continuously interact and transform each other. These things are not static and independent, they're interdependent and are always in flux. Complexity science has been advocated in nursing as a way to study human health in a more flexible way than what a Newtonian approach allows for. And it has been integrated in different ways in nursing education, clinical practice, as well as healthcare organizations and nursing management. Now, Bird and Strachan suggests that given the adaptive, nonlinear, dynamic, and contextual nature of human beings, complexity science provides us with a suitable framework for the design, implementation, and evaluation of clinical nursing interventions. So now, how do we use complexity science and Newtonian science in continuing to do suicide research and building nursing knowledge? So one of the things that has been advocated in the suicide literature is that there's an increased emphasis on qualitative research that will help us develop a deeper understanding of suicide while considering the context in which it occurs. The other thing is to use more mixed methods research. So the idea is that that will help deepen our knowledge as to how cultural and social factors interact with individual factors. And finally, using pluralistic, multidisciplinary approaches. So really what this means is being open and flexible and bringing together research from various perspectives. Of course, there is a place for seeing what risk factors are more closely associated with suicide deaths for a specific population, but let's also look at individual experiences. Let's also look at biological components. Let's look at all the different types of knowledge available and bring them together to better understand suicidality. Now, more specifically, one of the things we can do is if we're using complexity science and suicide research, is think of an individual as a complex adaptive system. So thinking of a human being as an entity that is composed of many components: physical, psychological, emotional, social, existential, and more, and acknowledge that even though we may not be able to tease out all of these components, and we may not necessarily need to do that, we can study the patterns that emerge for that individual person in a particular context. So clinically, some of this work is done in things such as behavioral chain analysis that is done in DBT, or when we're doing a safety plan and we're identifying warning signs. So we're trying to understand for this particular person, what are the situations, thoughts, feelings, behaviors, and how do they come together that tend to precede suicidal thoughts and behaviors. So let's keep doing that. Another way is to think of the therapeutic relationship itself as a complex adaptive system and study its components, how they influence each other, and how it adapts to its environment. So, for example, what kind of patterns emerge within a therapeutic relationship that may influence an individual to shift their attention from wanting to die to building a life worth living, for example. How does the context in which this relationship takes place influence the relationship? Are there factors, for example, in the inpatient hospital setting, in the community or the day program, that tend to make a difference in how this therapeutic relationship evolves? And along those lines, from a broader perspective, let's look at the mental health institution as a complex adaptive system itself. Is there a culture of blame that exacerbates anxieties and fears among nurses in our healthcare systems, which then influences the type of therapeutic relationships that they're able to build? Is there a heavy focus on standardized risk assessments without a person-centered approach that heavily influences the types of conversations that suicidal individuals have with their care providers? Now, one area that has gained a lot of attention recently, I'm not there yet, sorry. One more thing here. So Morrissey and Higgins, speaking of the healthcare institution as a complex adaptive system, called for a culture of openness where suicide is perceived as a possible outcome despite excellent standards of care, and one in which safe and supportive spaces are created where staff can discuss and reflect on their anxieties when working with suicidal individuals. Is that something that we do? Is that something that we can aim towards in our healthcare systems? Now, an area of interest very much related to this that has gained a lot of attention recently is that of machine learning and complexity. So we see in the literature some studies that speak of complexity, and it's not necessarily complexity science, but they do speak of complexity when trying to understand suicidality. And basically what it is using technology, and for many of the studies is ecological The people have cell phones, and then they constantly log their risk factors, how they're feeling, whether or not they're having suicidal thoughts. And then that information is used to build models and networks that can help us organize large data sets and help us see the associations between risk factors. Now, the reason why I say this is not necessarily complexity science is that they suggest that our inability to predict suicide accurately is likely due to simplified explanations, and the prediction is enhanced by identifying, or maybe enhanced by identifying, complex combinations among risk factors. So it is still working under the assumption that there is a finite number of internal and external factors, and the technology is giving us a venue to build a better equation using a more advanced algorithm. So it's not necessarily complexity science in that way. However, it clearly can give us a lot of information that we're unable to gather otherwise, that can help us better understand this suicide phenomenon. Now, one of the things that are really interesting that have been done is, for example, some work by DeBurs. They look at a network, and within a network, they can point out some symptoms that are deemed to be more central, and therefore connected to other symptoms, and therefore assumed to be the most contagious. So it helps us point out some of those symptoms that really stand out, that are central, that could themselves be a venue for intervention. Now, this may be really helpful at the individual level, and a field for intervention and further study. At the same time, we have to be aware that central symptom or a contagious symptom for a population may not apply to a particular individual person within their social, cultural, political, etc. context. The other thing to consider, as Stillers would tell us, is that we have no way of predicting the importance of that which is not considered. So of course we can gain a lot more knowledge about these risk factors and how they're associated through this work. At the same time, if we are using a complexity science worldview, we have to acknowledge that there may be factors that we didn't think of asking, that we're not considering, and that limit our ability to figure out the full puzzle, for lack of a better way of saying. So now, taking all that into account, this brings us to practice implications. So based on all these things, what are some recommendations? So number one, really prioritizing the therapeutic relationship. And this isn't anything new. This is what we do as nurses. We want to, of course, keep in mind that the person in front of us is the one that is the expert in their own lives. More than any kind of research or anything that anybody says, it's that person in front of us who is the expert of their own lives. And also that what will potentially make a difference for them is also unique to that individual person. So let's give people an opportunity, as much as we possibly can, to talk about their experiences and look at some of the factors that may impede that from happening. What gets in the way of us being able to speak to our patients and give them that ability to do so. So there's so many systemic issues. We talk about nursing shortages, we talk about, prioritizing. In acute psychiatry, sometimes we call it, we're just shutting out fire after fire. So what can we do so that we have the time to give people the time that they need to tell us what it is that's happening? And these are, of course, not easy solutions. Now, as we do that, let's explore the patterns that emerge for that particular person in their specific context when faced with the factors that lead them to consider suicide as an option. And again, as I mentioned before, we do this when we're doing safety planning, we're doing behavioral chain analysis. We do this, and I think intuitively we do it anyways. And this is what our experience, our clinical experience is. We're looking at all these patterns that we see among our patients. Now, what would happen if we talk to each other about the patterns that we see? And then we can understand by talking to other clinicians with other experiences what other patterns may develop that can then help us in our work, of course, keeping in mind that each person is an individual. But again, these patterns can help us see things that we hadn't seen before and talking about them. Now, as we do that, we may be able to better know how we can use the therapeutic relationship as a basis for intervention. So this may mean at a particular moment in time for this person is when involvement of family members may be more helpful, or involvement with community agencies, or whatever it may be. Now, the next part is to be aware as to how factors of the physical and social environment influence patients' and clinicians' behaviors. Are there certain things that we notice, for example, in an inpatient psychiatric unit that may precede suicidal behaviors amongst our patients? Or on the other hand, that appear to instill hope. So even thinking of things like how the space looks like. Do we have common areas where people can connect with each other and share experiences? Do we encourage that? At which point do we not encourage that? And do we consider for each particular person whether or not we should or should not encourage that? Do we have certain books, certain quotes, certain even the way of how the environment looks that influence how people think about these things? Is there certain rules in our environment that take agency away from our patients? Are they driven by this risk aversion, fear of blame mindset that we come up with these rules that permeate how we work, and that potentially, if we're always instilling rules, take them away from meaningful therapeutic conversations? Do we have education needs in our environment that need to be addressed? Do we have certain policies and procedures in our healthcare organizations that imply that suicide can be predicted? And does that have an impact on our social environment? Now, the next thing is to examine the fit of the clinical tool to its context. So, of course, in a perfect world, I would be able to build a very strong therapeutic relationship with any patient at any time. However, we know that that's not necessarily reality. So say if I'm working in an emergency department, and I have somebody coming that has had a suicide attempt or is having thoughts of suicide, I may not necessarily have the time to develop that very in-depth therapeutic relationship and try to understand their patterns and how all these factors interrelate for them. And it may be that the best fit at that moment to use one of our standardized risk assessment tools to help me try to understand quickly whether or not this person may need an inpatient admission or not. Of course, not just that, but in addition to other things. But does that mean that we need a standardized clinical tool in every context in which we provide healthcare to individuals experiencing suicidality? It may fit at that emergency department, but it may not necessarily fit everywhere that we work. And if we're using this tool, are we using it as a way to predict risk, which we have limitations on doing that? Or are we using that situation as an opportunity to discuss this person's suicidality and to understand from their perspectives what it is that's happening? Are we scoring this tool? Do we need a low, medium, or high risk score? And again, am I using it to engage this person or to try to predict whether or not they will try to die by suicide over the next several hours? And lastly, use existing knowledge as a venue for intervention. So of course, Newtonian science and all the research that has been done on suicidality has given us a lot of knowledge about risk factors. Let's use that. Let's keep doing CBT. Let's keep doing DBT. Let's keep looking at DNA patterns and neurochemistry and what it means to have social support versus not, and how all these things come together. Let's really focus on the intervention part and meeting people's needs and identifying their needs more than the predictive part of it, that and the risk, the predictive part of it that we simply may not be able to do as much as we would like to. Now, finally, just leave you with some concluding thoughts. The overall number of suicide deaths has increased worldwide over the past several years. Most of suicide research to date has been based on a Newtonian science worldview. Newtonian science holds the view that an object of study is influenced by a finite number of internal and external factors, making suicide predictable and preventable, which has had implications for the care that we provide. A complexity science perspective offers an approach to the research of suicidality that embraces multiple perspectives and accepts the reality of unpredictability. And not just that, but I would say that even just the view that the future is open and unpredictable can give us a sense of hope and optimism, that even though a person may be in a really difficult place at the moment, it doesn't necessarily mean that that's not going to change for them. And finally, a complexity science perspective allows for a human being to be seen as a whole, unique person, interconnected with their environment and with the capacity to evolve and grow in unmeasurable, unpredictable ways. And that's it. That's all I got.
Thank you very much, Jen. That was excellent. We now have some time to turn it over for questions. There's nothing in the chat, but I would say, Jillian, since you turned on your camera, do you have a question for Jennifer, or would anybody like to jump in with their first question?
I was mainly just coming on to do a clap.
Oh.
that wasn't just the emoji clap. It was a great presentation. I guess I do have a question on, are there any like methods, guidance, papers on how we actually do research using a complexity science framework moving forward for suicide research? You've convinced me that this is the way to go. But I guess it was a very good presentation, but I'm just wondering, how does one actually do that? How do we switch from the risk factor approach in research? And as you know, I'm predominantly quantitative. So how do us quantitative researchers switch it up, since clearly what we're doing isn't helping?
I wouldn't say that what we're doing is not helping. Thank you for the question. That's a really good question. I wouldn't say that what we're doing is not helping. I would say that what we're doing is simply not enough, and we need to do more. And we need to look at other ways of studying suicidality and then combining it with the quantitative knowledge that we have to better understand this complexity, right? There aren't any guidelines as to how to do this when it comes to suicide. However, there was a study done looking at using complexity science, looking at violence in patients, psychiatric units. And one of the things that they found, unsurprisingly, is that their violence risk assessment tools did not necessarily predict violence in the way that they expected to, and that there were certain things in the context, like there was, staff turnover or certain situations that happened in the unit that led to events happening more. So really looking again at those like physical factors. So I would say that, sorry, I think I went off track a little bit, but this is where complexity science has been used in research in psychiatry, not in suicide, but in this way. I would say let's do mixed method study. Let's look quantitatively at what are the risk factors, what are those individual characteristics for that person or from a population, and then qualitatively let's ask people what it is that they're experiencing, so that we can understand how the individual factors that we can quantify interact with the factors about the person's experiences and how things interact for them that we can't quantify. And then that way we can get in a broader, deeper understanding for that person and for other people.
Great response, Jen. I'm just looking to the chat. There's a couple of comments just on the excellent presentation, provocative, knowledgeable, invigorating, really positive. Are there any questions from the participant group? Don?
Hi, good evening. Excellent presentation, certainly. I echo the comments from the other people. This really, I've been doing this for 40 years and certainly feel very optimistic after seeing the presentation here tonight. It took me back to when doing undergrad education about King's nursing theory and the personal system and the social system and the interpersonal system, and taking a nursing theory like that and linking it up with the machine learning and Newtonian science and all that. I think this is something that's really going to tighten up suicide assessment. And the thing that really struck me is that we get caught up in these old scales and old beliefs that things are going to go a certain way, and as the presenter pointed out, they're the opposite in reality. And so merging all these different sciences, I think nursing as a discipline has a real great opportunity to embrace these things and as part of our practice. So this was really really something pleasurable to see here tonight, and certainly again left me feeling very optimistic for the future.
Thank you. Thank you so much for your comment. That's great.
Yeah, good luck with your endeavors. You're going to be, I hope you become one of the leaders on the stage for psychiatric and mental health nursing. This was very well done.
Thank you.
I agree, Don. Excellent presentation. I have a question as well. It kind of builds on what Jillian had said and somewhat related to Don. If our current and existing, suicide or like assessment tools, the ones that, the clinicians are familiar with and are using that Newtonian science approach, linear, looking for the risk factors. The more risk factors we can identify, the better we can predict a high, low, medium. Have you come across something that is more comprehensive, that does bring in some of the, say, individual elements, the social elements, societal stigma, like some of the other parts? Like, have you found a tool moving in the right direction to capture some of these that maybe is being used currently in clinical practice somewhere?
It's a good question. I haven't come across one, but I haven't searched for one either. So there may be one out there that I haven't searched for. I think the one thing about tools, like when we did some work in my hospital about, we need a tool, what's the tool? And there's all this information about tools, is that a lot of them very much want to score, right? And, going for low to medium and high, and they're looking at different like non-static risk factors. The person had a suicide attempt before, and then static risk factors. Did they have a risk suicide attempt before? And then some more dynamic risk factors, like are they going through some kind of psychosocial issue? So they aim to score, and I think that's the difficulty that we get into, that the score may just not, the questions that are there are based on a population of study that does not necessarily reflect the person in front of us. So if we're scoring someone based on the general population, then we're not necessarily giving thought to all the multiple things that affect this individual person in particular. And I think it would be really difficult. I think we could have some prompts that, look to see, what kind of social things, and that can give us a lot of prompts to try to understand this better. And I think that would be a really good skill to have. I do think that overall we just have to keep this person front and center and not let the tool, whatever tool it may be, take away from the person sharing with us what it is that they're experiencing. And I think that happens a lot. We're like, okay, we have to do this assessment. I'm going to ask you this set of questions, but then we're not giving time to other things that may not be in that assessment, and they're going to be different for every single person. But I will definitely take a look to see if there is a tool out there. In the past few years, I looked at this in 2018, so it was a little bit ago now in terms of how fast research happens, and I'd love to take a look and see if there's something more comprehensive that kind of takes some of these things into account. And I will send it to you. I will email it to you if I find it.
That would be great, Jennifer. Thank you. Are there any other questions for Jennifer? I have in the chat, what a great idea of having a set of standardized prompts that don't necessarily require a standardized response tied to a number. Really pulling in, I think, like you said, a qualitative aspect to our assessment of suicide risk, like for the population we're working with. Very interesting stuff. Any other questions?
I think there's one in the chat that might have been missed. The instilling hope, would you be able to comment on research on this intervention?
Thank you very much, Jillian.
Not as much as I would like to. I know there is some literature. There's some studies that have been done, and it's for the most part qualitative studies. Instilling hope would be looking at how do nurses instill hope in patients? What are some of the conversations that are said? How does this work? But I wish I could tell you more. I know there's some research done on it, and I know that it's primarily qualitative. I know there likely isn't enough, and I know that we can probably do a lot more than that. I know there isn't any mixed methods research done on instilling hope. We're also looking at certain outcomes. But yeah, sorry, I don't have much more to say about that one. But other than we should do more of it.
And I'm thinking that most of us in attendance are hoping to see more in the future. This was an excellent topic, a really thought-provoking topic, especially for those of us that have been, in this direct patient care area for a long time. It would mean a rethinking of how we do some of our most vital assessments, in acute care or in the community. So no, this has been an excellent presentation.
Thank you.
And I think on that note, then it might be the right place to wrap up the webinar. So on behalf of the Canadian Federation of Mental Health Nurses, I'd like to thank Jennifer for making tonight such a great webinar. I'm sure we're all going to be taking away something positive from this experience. A recording of the webinar will be posted to the members area of the new CFMHN website, and an email will be circulated along with your certificate of attendance, also including a link to a short 2-minute feedback survey. So just a reminder to please give us some feedback. That being said, thanks to everyone for attending, and good evening to everybody.